Morning, everyone. Today we are going to see the anatomical landmarks and their clinical significance. So basically, in Department of Prosthodontics, we are mainly deals with fabrication of removable partitions, complete dentures, placement of implants, and also fabrication of maxillofacial prostheses. So before learning the complex treatment procedures or the fabrication methods, it is basic to understand what are the different anatomical landmarks that are present in both maxilla and mandible. So today we will be seeing what are their clinical significances and how they are classified. So the first one, in the maxillary arch, these are the anatomical structures. To not to familiarize the terms, first I will explain the various anatomical landmarks. So in the maxillary arch, anteriorly we have the labial frenum, then we have a labial vestibule, then we have the buccal frenum, then posterior to the buccal frenum we have a buccal vestibule, then posteriorly we have a maxillary tuberosity. Distal or posterior to the tuberosity we have a depression called Hamlet notch. Then the midline area we have an incisive papilla in the anterior region and the mid-palatine raphe, and anteriorly we have the rugae. So these are the anatomical structures which are present in the maxilla, and also in the mandible we have the labial frenum and the lingual frenum. Then we have a labial sulcus and the buccal frenum and the buccal sulcus. Here, posteriorly, we have a buccal shelf area, and the posterior limit is the retromolar pad, and the lingually we have the distal lingual sulcus, and we have a mylohyoid ridge on the uh, mesial aspect of the edentulous ridge or on the mandibular ridge surface. So these are the basic anatomical structures which are present in both maxilla and mandible. Then now we will see each one in detail. So the first one is the labial frenum. In the maxillary arch, the labial frenum, it is a fold of mucous membrane which is present at the midline. So as you can see in the picture, here, here in the midline area, a fold of mucous membrane is present between the edentulous ridge and to the upper lip. So this mucous membrane, a fold of mucous membrane, is movable with the muscles of the lip. So the clinical significance of this labial frenum is that when we are fabricating a complete denture, if there is proper relief is not given for the labial frenum or to the posteriorly to the buccal frenum, what will happen is during mastication or during speech, it will cause movement of the labial frenum and it will result in the dislodgement of the denture. So in order to get a proper seal or to get a proper retentive denture, we have to give a proper relief in the complete denture or the partial denture which is replacing an anterior tooth. So adequate relief should be given for the muscle activity and for a proper denture seal. So in the picture below, we can see that there are two contours, A and B. So the correct contour of getting a labial frenum relief is the contour number A, contour named A. So as if you are trimming the labial frenum area like in a B shape where we are giving an improper contour, it will result in seal breakage and the retention will be uh, lost. So during the impression procedure itself, we have to record the labial frenum by giving both upward and downward movement of the upper lip. So a proper labial notch will be created in the impression procedure. So during the primary impression and the secondary impression, during the border molding procedure itself, we have to record the labial frenum. Same way in the buccal frenum. When compared to a labial frenum, buccal frenum is a single or double folds of mucous membrane, and it is a broad and fan-shaped mucus attachment, mucous membrane. So in the labial aspect, I told it is a narrow attachment, but in the posterior aspect where there is a buccal frenum, it is broad and fan-shaped. This also moves with the muscles of cheek during speech and mastication. And for proper retention of the denture, adequate relief for muscle activity, adequate relief should be given for the muscle activity. So In the impression, these terms like the label freedom and the buccal freedom will be recorded as the label notch and the buccal notch. So in between the label freedom and the buccal freedom, we have the label vestibule. So the label vestibule is extending between the label freedom and the buccal freedom. The width and depth of this label vestibule should be recorded during the border molding procedure itself or during the complete edge fabrication itself. If the proper sulcus width or depth is not recorded, if it is an overextended impression or overextended label flange, it will result in an instability or soreness of the mucosa. Same way, if it is an underextended label flange, it will result in breakage of seal and also it will result in loose denture. So the proper contouring gives optimal aesthetics also. So when we are giving the border molding, the objectives of impression making, we know that we have the features like retention, stability, support, and the last one is aesthetics, preservation of alveolar ridge and aesthetics. So in the aesthetics, when we are doing the border molding itself, we have to create the proper support for the cheek and the lips. So the width and depth of the sulcus is also influencing the aesthetics of the denture. So the proper contouring gives optimal aesthetics when the denture is fabricated for the patient. Then we have the buccal vestibule. So posterior to the buccal freedom, between the buccal freedom and the Hamlet notch, we have the buccal vestibule. So same way as we told for the label vestibule, the buccal vestibule also should be recorded to record adequate depth and width of the sulcus. So the improper extension, the overextension of the buccal flange will result in instability and soreness. If underextended, it will result in breakage of seal and loose denture. So how will you record the label vestibule and the buccal vestibule? So when we are recording the border molding itself, we have two methods like active method and a passive method. So in the passive method, we will be doing the movements. In the operator will be doing the movement, and in the active method, we will ask the patient to do the functional movements. So in the label vestibule, the passive method is we can um, hold the lip and the cheek area. We can do the upward, downward, and outward movement of the cheek and lip. So the buccal vestibule, same way we can do, but the posterior most area when we want to record the histobuccal sulcus, we have to take the help of the patient or the active method where we will ask the patient to move the mandible towards the right and left. Only then the coronoid process of the mandible will contour the histobuccal sulcus properly, because if this movement is not done during the functional movement, the coronoid process will create an interference with the denture borders and it will cause distortion of the denture. So the buccal vestibule should be recorded both by the passive and the active method. So in the denture we have the buccal flange. So anteriorly we have a labial notch, labial flange, then the buccal notch and the buccal flange. Then posterior to the buccal flange, we have the maxillary tuberosity. So maxillary tuberosity, it is the distal end of the denture. It must be covered properly to get a proper stability and retention for the denture. So in some patients, there will be some growth enlargement or fibrous or bony enlargement for the maxillary tuberosity. So these enlargements in the posterior most area, the maxillary tuberosity is considered as a secondary stress bearing area. So, and also, if there is an enlargement, it should be removed by the surgical correction. Then we have the Hamlet notch. Hamlet notch is located distal to the maxillary tuberosity. It aids in locating the posterior palatal seal. So, how will you record the Hamlet notch? Hamlet notch is a depression like uh, extension which is posterior to the maxillary tuberosity. So we can just palpate the Hamlet notch by using a mirror, or there is something called T burnisher. T burnisher will be having two ends, one rounded and one a blunt end. The round end should be kept facing the palate, and the hamla knots can be located by using the T-burnisher. In the mouth mirror, in this picture, you can see that the mouth mirror is the border of the mouth mirror is correctly exactly fitting into the shallow depression area which is posterior to the tuberosity. So the extension of the hamla notch, the position of the hamla notch should be located to get a proper posterior limit of the uh, complete denture. If it is extending towards the hamla notch area, then during opening and closing movements, it will cause overextension, the soreness of the mucosa. Then we have the posteriorly the vibrating line on the PPS area, the posterior palatal seal area. The posterior palatal seal area is located between the anterior vibrating line and the posterior vibrating line. The vibrating line, it is a junction of the movable and immovable part of the soft palate. According to the location, the vibrating line is located 2 mm anterior to the fovea palatina. What is fovea palatina? We will see in the next slide. And this vibrating line also aids to establish the posterior palatal seal. The distal end of the denture should extend at least to the vibrating line. So the posterior palatal seal area, it is, as I told, it is extending between the anterior vibrating line and the posterior vibrating line, and um, it is distally it will be extending from one hamla notch to the other hamla notch. The size and shape of the posterior palatal seal will differ according to the shape of the soft palate of the patient. Then the fovea palatina. Fovea palatinum, it is a bilateral indentation which is located near the midline of the palate, and it is formed by coalescence of several mucous gland ducts. So these are the mucous gland ducts which are present in the oral cavity, and it is located posterior to the junction of hard and soft palate, and it aids in determining the vibrating line. So the fovea palatinae, in those patients who are having a thick ropey saliva, it is better not to cover the fovea palatinae because this thick ropey saliva will come in between the denture and the mucosa, and it will result in dislodgement of the denture. So in those cases, it is better not to cover those fovea palatina. So the fovea palatina is located posterior to the vibrating line, and uh, the posterior limit of the complete denture should be kept at the posterior vibrating line. Then the hard palate. The hard palate, when we are talking about the hard palate, the posterolateral slopes of the hard palate is considered as a primary stress bearing area. So it supports for the maxillary denture, and the posteriormost area is a primary stress bearing area where there is a cortical bone support and also a thick keratinized mucosa is present. Anteriorly, we have rugae, which is considered as a secondary stress bearing area. Then we have the alveolar ridge. Alveolar ridge is residual bone with mucous membrane. Is the residual ridge is a primary stress bearing area. The alveolar ridge should be having proper thickness, or it should be covered with a thick mucous membrane. A thin alveolar ridge is not considered as a primary stress bearing area, mainly in the mandible. So this alveolar ridge will be recorded as a alveolar groove in the impression. And the incisive papilla. The incisive papilla is an elevation of soft tissue over the incisive foramen or nasopalatine canal. It is located on or labeled to the ridge. The impingement of the denture onto the incisive papilla. So, as we know, the incisive papilla, there are incisive nerve which is present in passing through the incisive foramen. So when there is impingement of the incisive foramen or incisive papilla, it will result in burning sensation of paresthesia and pain in the uh, maxillary region or in the maxillary anterior region. So incisive papilla is a main relief area in the maxilla, incisive foramen, the mid-palatine raphe, or any maxillary tori. These are the relief areas of the maxilla. So in the complete denture, a proper relief should be given in the denture in order to avoid impingement of the incisive foramen, incisive nerve. Then we have rugae. Rugae is a irregularly shaped rolls of soft tissue. It is a secondary stress-bearing area. It should not be distorted in the impression. So we have up and down elevations in the maxillary anterior region, which is called rugae. These are soft tissue based on the angulation, which is located perpendicular to the occlusal forces. These are considered as secondary stress-bearing areas. Then we in the midline area we have the median palatal raphe. It extends from the incisive papilla to the distal end of the hard palate. It's a thin mucosal covering and non-resilient. In the bony structure, we know that just below, behind this mucosal covering, we have the mid-palatine uh, suture, mid-palatine suture, which is covering the which is covered by the mucosa. So anteriorly, we have the median mid-palatine raphe. It is a thin mucosal covering and non-resilient, relief adequately to avoid trauma from the denture phase. So the thickness of mucosa in the midline area, just above this mid-palatine suture, is less. The thickness is very less. So if proper clearance or proper relief is not given in this area, it will result in trauma to the mucosa. So till that is the anatomical landmarks of maxilla. In the mandible, we have the labial frenum anteriorly. The labial frenum is a shorter and wider than the maxillary frenum, adequate relief for the muscle activity. Then proper fit around it maintains steel without soreness. So these factors are same as we are talking for the, as I told, for the maxillary denture or the maxillary labial frenum. The maxillary labial frenum, as we're giving relief in the denture, the adequate relief should be given for the mandibular frenum also. Mandibular frenum, it is a muscle attachment mainly. It is a mendalis muscle attachment. So if the relief is not given, it will result in soreness of the mucosa. Then we have the buccal frenum. The buccal frenum is seen on both right and left side. So adequate relief for the muscle activity. If it is not given, it will result in soreness. If it is underextended, it will result in seal breakage. So in order to get a proper denture seal, it should be recorded in the impression stage itself. Then the labial vestibule. Labial vestibule is seen between the labial and buccal frenum. Overextension causes instability or soreness. The muscle attachment close to the crust of the ridge limits the denture flange extension. Sometimes what will happen in the labial vestibule area, there will be muscle attachment which is close to the ridge. So in those cases, it will limit the denture flange extension. So if the muscle attachment which is there in this area, if it is in a much higher level, it is called, the muscle attachments are very close to the crust of the ridge. So in those cases, we will not be able to extend the flange into too much depth. So what will happen? There will be less seating area for the denture. So when there is reduced supporting area or the seating area, it will result in reduced retention of the complete denture. So whenever, if it is highly required, then we have to go for a surgical vestibuloplasty in order to get the increased depth of the vestibule. And always it should be recorded to record the adequate depth and width of the vestibule. Proper contouring gives optimal aesthetics.